We're talking more this episode about community benefit, a key aspect of hospital finances, and the subject of growing attention in Washington and St. Paul. This week we'll hear from the tax expert who literally helped write the IRS regulation on the subject. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm Tim Nelson. In this episode, we're talking with Keith Hearle, founder and president of Verité Health Consulting, based in Alexandria, Virginia. He's a consultant, a former investment analyst, and developed the Catholic Health Association's Community Benefit Framework, one of the founding documents in the field. He literally wrote the book on community benefit in hospitals, and he was in Minnesota recently for an MHA finance conference. I asked him to give me a history of the concept that government and hospitals consider a core principle of nonprofit healthcare.
To get to the origins of community benefit, we need to go all the way back to 1956, when the IRS promulgated a revenue ruling. It was 56-185. It basically said that to be a tax-exempt hospital at a federal level, you had to provide charity care up to the financial ability of the hospital. So that was the standard under which hospitals were granted tax-exempt status at a federal level. Then a few years later, you had the passage of Medicare and Medicaid, and so questions were raised about the need for charity care. We have now health care for seniors, we have health care for low-income people. So why would we need charity care? And so the basis for granting exemption needed to change, and it was changed to what's called the Community Benefit Standard. That's another revenue ruling, 69-545.
And from 1969.
From 1969. And that revenue ruling is short. It describes two types of hospitals, one that has an open medical staff, operates an emergency room that takes all patients no matter what type of insurance they have. And if that hospital has surplus funds, those funds are reinvested in facilities, education, research, those types of things. So that obviously is the charitable hospital. Then it describes another hospital that closed its medical staff, even though you've got qualified physicians in the community. The dollars in surplus inure to private individuals, things like that. So that clearly is not an exempt hospital. And so that was the standard, Revenue Ruling 69-545, all the way up until 2010 when we had the passage of the Affordable Care Act. Before that, though, in the 80s, there were some concerns about findings from academics and analysts that there weren't too many differences between for-profit hospitals and nonprofit hospitals when it comes to their uncompensated care. And the Catholic Health Association specifically got concerned about that. The sponsors, the sisters that actually own and operate these health systems, were wondering, is this really a place we want to put our resources? I mean, we have a mission as a church to address poverty and other community concerns. So if charitable hospitals aren't doing enough, and so it really kind of rocked the whole that whole sector of our healthcare system.
So they were looking at their own facilities and their own hospitals and thinking about this?
They were thinking about it and wondering, is this really a mission that's being carried out effectively by running and owning hospitals? Well, the Catholic Health Association heard that and said, well, we need a better way to define what community benefits are and differentiate things that are truly benefiting the community from things that are more commercial and benefiting the organization. And Larry Lewin, who founded a firm called the Lewin Group, he wrote an article that said, well, so far the analysts haven't gotten it right. Nonprofit hospitals do a range of things that benefit communities beyond simply charity care and uncompensated care. That includes educating health professionals, so graduate medical education. It includes offering clinical programs or subsidized health services that, we run these clinical programs at a loss, like a psychiatric unit, but we do that because the community really needs those services. And by the way, a for-profit hospital, they would not do that. They just would not run a psych unit because they're accountable to shareholders and not to the community. And so the Catholic Health Association said, well, we need to put some meat on the bones of this community benefit standard, which a little squishy when you look at it. And so they developed something called the social accountability budget. And I was a young financial analyst way back in the day and put together some worksheets and guidelines and methodologies for accounting for and reporting all these different activities that survives today in the form of IRS Form 990 Schedule H. And I had a role actually writing up the instructions to the schedule because of my role with the Catholic Health Association. And so that's a lot of the history of kind of how we got to where we are today.
So you talked about this definition and this calculation being squishy initially. Obviously, there's been a lot more attention to it in the subsequent years. What does community benefit look like now? What are the categories? What counts? What doesn't count? How does a hospital count it? And how do people who look at hospitals count it?
Great question. At a high level, there's 4 objectives. The first is improving access to care for lower income people. And so in that category, we have charity care still counted. It's now called financial assistance. That term was adopted after the ACA passed. We have care provided to Medicaid recipients. We also have care for people with other means-tested government program benefits. And then we also have this subsidized health services category. That's like the access to a psych unit. So that's the access objective. Second objective is enhancing public health. So if we do things to educate the community about the risks of different health diseases or concerns and the like, that's an example of an initiative that would count under that objective. It's called Community Health Improvement Services. So that's a category that we put numbers to. We also, to achieve that objective, we make contributions for community benefit, and this is to other organizations that do this kind of work. Then the third...
For instance, like a food shelf or a vaccine program or something like that.
Exactly, or a contribution to a local food market in an area that has a food desert, so there's no grocery store. I mean, that's an example of something hospitals will fund, and you get to count it as a benefit to the community, the dollars going into that. The third objective is advancing generalizable knowledge. And there are 2 categories that count under that category. Health professions education. It's where we're training the next generation of health professionals. And it's not all types of education that trainees get. It's the education they need to actually be licensed to practice in their state. Then we have research. And it's not all research. It's publicly funded or tax-exempt research. The fourth objective is relief of government burden, which kind of gets back to why hospitals get exemption in the first place. If hospitals weren't doing all these things, the cost to government would go up to build hospitals to take care of Medicaid patients or provide more public health services because the hospital isn't doing it. It falls back to the local health department to take care of it. So that relief of government burden is kind of a fundamental component of all of this work.
So in a strict sense, why does this matter? I mean, why not just reduce the cost of healthcare for everyone by as much as this community contribution is? Why is it important to make these investments rather than save that in the health system now?
This comes out of a long history of why hospitals were planted in different parts of the country. There's a need for healthcare services in our community, and so we need to have an effective organization set up. And government thought back then that setting those up as a tax-exempt organization is exactly the right thing to do. They didn't see burdening these organizations with tax as something that was good for society. But then you have, okay, now let's prove that the hospitals are actually doing everything they can to earn that exempt status. And that's where this sort of goes full circle to providing these types of community benefits.
Well, I can imagine, and some of these benefits are beyond simple care as well. Preventive work, things that you don't want to wait for people to need the care to come in. If you can prevent them from getting sick, it may be more essentially cost effective.
That's exactly right. And the term is community health improvement. When I was working with IRS officials on Schedule H, that phrase kept coming up and coming up and coming up. Is this something that is going to improve the health of the community as opposed to something that is good financially for the hospital and help build the organization up? And that's why there's some things that we don't count as community benefit. Does generating bad debt on an account, does that improve the health of the community? No, it actually leads people to be very stressed about bills that they were unable to pay. Charity care does improve the health of the community because you've improved access to care and you've relieved the burden of that medical debt for the household.
Now, you talked about how in the development of this sort of concept, states started to pick this up and think about it themselves. Obviously, Minnesota has had some discussions about this up at the Capitol. Mm-hmm. What does charity care look like in Minnesota? Is it just a matter of the federal tax code? Do we differ from other states? How does it look here?
Well, you can put the states into two buckets: those who have been active on their own in this whole field of community benefit and financial assistance and the like, and those that have not. And Minnesota has been active. The state has gone beyond those minimum requirements, and if they filled in the blanks in a few places where the feds did not go. So you look at the Affordable Care Act, which changed forever what it means to be a tax-exempt hospital. It laid out an outline for what financial assistance policies need to look like and some aspects of what the collections process needs to look like. But over time, states have stepped in saying, well, that's nice, but we need to tighten that up a little bit given our unique situation as a state, people who live here, the needs that are here, and the like. Minnesota hasn't gone quite as far as some other states. If there's one state that really has gone to great lengths to be very specific about community benefit requirements, it's the state of Oregon. They have established a spending floor for community benefit.
And Minnesota doesn't have
Minnesota doesn't have a spending threshold yet. Minnesota does have some requirements around financial assistance, charity care, and a couple of those are fairly recent. There's one that requires screening uninsured patients, and if you don't know what the insurance is for a patient, you need to screen those individuals as well. And the idea is to see if those people qualify for the hospital's charity care program, or maybe they qualify for insurance and we can help get them signed up or eligible or take advantage of what they already qualify for. Oregon has said if you're at 200% of federal poverty, the federal poverty guidelines, if you're a hospital in Oregon, those patients qualify for free care, 100% discounts. And then there's a sliding scale of discounts up to 400% of the federal poverty guidelines. Minnesota hasn't gone there yet. The feds didn't lay out any eligibility criteria at all. They simply said, as a nonprofit hospital, thou shalt have a financial assistance policy. It shall be approved, adopted by the governing board or the authorized body of the hospital, things like that. So it's not as nearly as specific as what Minnesota and a series of other states have done in this arena.
So there's been a lot of attention on community benefit and nonprofit health, including a hearing in Washington this summer. What's going on here? Why the attention to it in recent months?
Well, we've had attention to whether hospitals that are exempt at a federal level are doing enough. That drumbeat has been drumming for many years, since the 80s, 90s. I mean, it's gotten a little louder just over the last few years, in part because there are a group of advocates that keep pushing for hospitals to do more. and there actually is some funding behind those efforts that didn't exist before. The academic researchers have gotten sharper in terms of their analysis of hospitals, and the Schedule H itself is a brand new data source that allows analyzing what hospitals are doing, the amount of spending and the like, and is it what is perceived needed to meet all the expectations of a not-for-profit hospital. So it's a combination of things, plus increasingly it's recognized as a major tax expenditure. The fact that we're not collecting federal income tax from all these not-for-profit hospitals across the country. I asked an IRS official this question, which is, if you look at all the different nonprofit sectors, where is healthcare? And healthcare hospitals, they're number 2 behind universities in terms of sectors of the economy that have large tax-exempt presence. So the fact that we've got a big exempt group of hospitals, it's a major source of funding potentially. There are some who've estimated how many billions of dollars could be collected if hospitals that are currently exempt under 501c3 lost that status. And it is billions, but in the scheme of things, looking at other dollars sloshing around in the federal government, it doesn't really seem like a lot of money that could be collected. And I think what the researchers misunderstand or underestimate is what would happen if lots of hospitals lost that exempt status. Do we really want that as a society for not-for-profit hospitals to lose that status? For example, it's rare to see a robust medical education program in a for-profit hospital. How do you make sure that our next generation of physicians have access to the best technology, the right experiences and the like? How do you do that in a for-profit hospital environment?
That's not a result you're going to see on the next year's earnings report if you're running a for-profit business.
That's exactly right. So it's no accident that you don't see too many teaching hospitals that operate on a for-profit basis.
Looking back at the history, obviously in the 50s and 60s, you had this landmark legislation. You have the landmark ACA as well. It feels like we're heading for another generational turn with the changes to Medicaid, with the changes to the ACA. There's a lot going on in healthcare finance right now. What do you think that's going to mean for community benefit programs, for community benefit spending in the United States?
Really good question. It's interesting. Back when we had health reform, it was recognized that the charity care spending is likely to drop. We're going to have more Medicaid coverage, more marketplace coverage. And the idea was, let's take some of those savings, if you will, and put that programmatically into other parts of community benefits like community health improvement services and the like. Well, now we have the exact opposite, where we're about to lose Medicaid coverage for lots of people. So the charity care demand is about to go up quite a bit. So at a federal level, my gut is saying we shouldn't expect major changes in the federal tax exemption framework for hospitals. Hospitals can make a very good case. Hey, we are really going to take it on the chin because of the lack of drops in our Medicaid reimbursement, more demands by uninsured people for healthcare services, and we're going to have to bear the brunt of that. And so does it really make sense for us you're going to be asking us to do more community benefits in that context? It doesn't really make sense that, those arguments I think will be persuasive. Where I do still see action happening though is in the states to try to uncomplicate getting access to financial assistance and the like, and just make those programs much more accessible for patients. So things like having a common application for financial assistance at every hospital so people get familiar with what it takes to apply for it, and you simplify the documentation requirements. So hospitals do have these policies, and it should be easy for patients to access financial assistance based on those policies. And states are going to be working to try to make that happen. But at a federal level, I'd be really surprised if something major changes in terms of Schedule H or the community benefit standard or some of these other requirements.
What are you telling hospitals? What should they be doing now to prepare for the increasing scrutiny of these programs and the potential increasing use of some of these community benefits?
Hospitals should be using care to get the numbers right. Hospitals still miss things that they could be reporting, and on occasion there are things they're putting on the schedule that shouldn't be there. Well, here's an example. The cost to sign people up for Medicaid. I've argued over the years that when people sign up for Medicaid, that opens up access to care for them, not just at the hospital, but at the pharmacy, at the physician office and the like. So if hospitals do the work to get people eligible for Medicaid, that's a benefit to the community. Plus, those are staff that don't have to work for the state Medicaid agency because these are people at the hospital doing the work. So it's relief of government burden. That's happening. There are other examples like we tend to underreport health professions education. We often report the training of interns and residents, physicians, maybe nurses, maybe a few other things that are Medicare allowable. But there are other types of trainees, lab techs, pharmacy techs. There's a whole array of disciplines where people are getting clinical experience at the hospitals. Are we capturing those costs? Well, we sometimes don't. Things like that.
So that over-reporting part, there's a lot of critics that have been focusing on that pretty carefully lately. What kind of things are they critical of? What are they looking at?
One criticism is that hospitals are given some flexibility when it comes to the cost accounting methods to apply to these different activities. I explained to the IRS that we have hospitals, large, sophisticated hospitals that have invested in cost accounting systems that do by far produce the most accurate numbers when it comes to a Medicaid cost or the cost to provide the psych unit. The critics say, well, we should have everybody use the same approach, which is a simple ratio of cost to charge. Well, that does not generate the most accurate result. So you see a principle in the instructions, which is use your most accurate cost accounting method. And for a critical access hospital, a simple ratio is that's what they have to work with. So their critique is we've got different methods. Well, there's a reason why we have these different methods, and the principle is whatever is most accurate, that's the method we must use. They say we shouldn't count health professions education because those programs don't really improve the health of the community, like the zip codes right around the hospital. Well, okay, so does that mean nonprofit hospitals should not train our next generation of health professionals? Okay, let's just stop doing that. That means access to care in 5-10 years, forget it. And these trainees, many of them do land in the community to practice when they're done, but they also go across the United States. And so this idea that we only have to have the local community as what we benefit is really not very well studied. Same with research. There are examples where nonprofit hospitals have made major discoveries, and do we really want hospitals not to do that? I mean, that ultimately is really benefiting the community. And I think if you look at where the COVID vaccines came from, some other discoveries, you'll see nonprofit hospitals being very much in the mix of that. So we have a better job to do as a healthcare sector in terms of responding to these concerns about what gets counted as community benefit. And I've said over many years, I have a hard time saying that this type of community benefit is more important than that type, or this one is less important than that. They are all important. Access to care is important. Improving public health is important. Advancing generalizable knowledge is important. And providing that relief of government burden is important.
Well, that's some great background on a growing debate about this issue. Thanks so much for your insight and your time today.
Pleasure.
Again, that's Keith Hearle, founder and president of Verité Healthcare Consulting, based in Alexandria, Virginia. I'm Tim Nelson, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.